Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Today we are going to discuss a very important topic in the week of acute abdomen in patient presented with acute abdominal pain, which is gallstone disease. I know you have studied something like that in semester 8, but if you notice the big spectrum of gallstone disease, which may affect the gallbladder, the bile duct, and the duct, for example, in the gallbladder, you might know stones in the gallbladder might lead to biliary colic or chronic calcular cholecystitis. Biliary colic, the patient suffer from abdominal pain, especially after fatty meal, or the patient might come with acute cholecystitis with its three stages, mucocele, pyocele, or perforation, which is somewhat rare in case of gall bladder due to one of these stone impact here and obstruct the cystic duct, or the very rarely carcinoma of the gallbladder, which might be caused by the irritation of the gallstones to the mucosa of the gallbladder, leading to adenocarcinoma of the gallbladder. All these are diseases caused by stones in the gallbladder. It's not only that, one of these stones might pass to the common bile duct like that and leading to obstruction here, which is causes calcular obstructive jaundice. It's not only that, it might obstruct also the pancreatic duct, leading to premature activation of the pancreatic enzyme and acute pancreatitis. And finally, stagnation of the bile here will lead to ascending cholangitis. Another issue, one of big stones here might lead to fistula, may do pressure necrosis of the gallbladder and duodenal wall, leading to cholecystoduodenal fistula, and this stone pass to the duodenum like that, and when it goes in the small intestine, it enlarges in size like a snowball, leading to what we call gallstone ileus. If we notice all these, biliary colic, acute cholecystitis, ascending cholangitis, pancreatitis, gallstone ileus, all these are known causes of acute abdomen. So it's very important to study gallstone disease in the week of acute abdomen. Here is the contents. I'm going to pass rapidly about the anatomy, physiology of and the pathology of formation of gallstones. As you see the anatomy here, if we open the abdomen like that, it's from Atlas Nil, you will find only, you can see the fundus only of the gallbladder with its known surface anatomy opposite the right ninth costal cartilage. If the gallbladder is inflamed, you will find tender point here, which is called Murphy's sign, we're going to discuss. But to revise the whole anatomy of this slide, you will find here is the liver, here is the stomach with the greater omentum attached to the greater curvature of the stomach and the pus in front of the transverse colon also attached to it, and the greater omentum cover most of the intestine like that. You know, it has some kind of mobility, this greater omentum. So when the appendix inflamed, it's around the appendix and isolate the inflamed appendix from the general peritoneal cavity, forming what we call appendicular mass. And also the same occurs here. If repeated attacks of inflammation of the gallbladder, the omentum also adhere between the stomach, liver, and anterior abdominal wall, isolating the gallbladder from the rest of the abdominal cavity. If we go nearer and elevate the liver like that, you have to elevate the liver to be able to see the gallbladder resting in the gallbladder fossa on the undersurface of the liver. But also we can see another type of omentum, which is the lesser omentum. Below the lesser omentum, in which the probe is introduced, behind the lesser omentum is what we call the lesser sac. We just hear the lesser sac in acute pancreatitis, which is the site of the formation of pancreatic pseudocyst. If you can notice here also, this is the free border of lesser omentum. It's free because all other borders are attached, as you see. This free border contains very important structure. Behind this free border, there is opening, this opening called the foramen of Winslow, which is the connection between the lesser sac and the rest of the peritoneal cavity. We're going to see a close view of this free border. In this free border, you have to see three important structures: the hepatic artery, the portal vein, and the common bile duct. We applied this knowledge in hepatic trauma. In hepatic trauma, we might apply this Satanisky forceps on this free border to occlude both the portal vein and the hepatic artery to be able to control the bleeding from the liver in case of hepatic trauma, Please revise the hepatic trauma and what we call Bringle's maneuver. Bringle's maneuver, you apply Satanisky forceps or vascular clamp over the free border to obstruct the inflow of blood to the liver, so you will be able to see the source of bleeding and control the bleeding. Back to the biliary system again, you can see here the right hepatic duct, which collected the bile from the right loop, and the left hepatic duct that collects the bile from the left hepatic loop. Both go to the common hepatic, which passes the bile to the gallbladder. In the gallbladder, it absorbs water, so the bile becomes more concentrated, and it secretes only mucus to protect its mucosa from digestion by this bile juice. And when we eat fatty meal, this gallbladder contracts, pushing the bile again into the cystic duct and down to the common bile duct to the duodenum to meet the food here. You can see here the common bile duct, which is with its different parts, and you can notice also it joins the major pancreatic duct to form a common channel which dilates, forming duodenal papillae, both open through a common opening at elevated part of the duodenal mucosa called the duodenal papillae. So here the duodenal papillae and the ampulla of water. What I want you to notice also that this common channel is gathered by a sphincter complex called sphincter of Oddi. What I want you to remember, this sphincter must be cut. If we have a stone here in the common bile duct, we want to extract through the ERCP, we have to cut this sphincter to remove the stone. It's called the sphincterotomy, and the stone extraction is done by ERCP. Here, a rapid view of the blood supply. You can see this cystic artery, the blood supply of the gallbladder coming from the right hepatic artery. You remember, this is the common hepatic which is present in the free border of the lesser omentum. Nerve supply, you have sensory, parasympathetic, sympathetic. This explains why biliary colic is referred to the right shoulder, stomach, and right scapula respectively. This just explains why pain is referred to these regions. Sure, you know the function of the gallbladder: store, concentrate, and secrete mucus. Here is the composition of bile. Why I have to remember the composition of bile? Bile is formed of certain substance dissolved in water. Dissolved in water. If you notice cholesterol and the bile pigment, we have this cholesterol is a fat. How it is dissolved in water? Because it's present in a certain concentration with phospholipid, especially lecithin, and these bile acids or bile salt. The three form what we call a micelle. The cholesterol molecule are in the center, in the micelle like that, and surrounded by the lecithin and bile salt with its hydrophilic part outside. So all this micelle is dissolved in water. In certain situation, when either cholesterol increased or the bile salt decreased, so we will have cholesterol molecules not formed in this micelle, so it will be separate in the bile like that, and it will precipitate, forming the cholesterol stone. The bile pigment, by the bile pigment I mean the bilirubin, which is responsible for the color of bile. We have two types of bilirubin, as you have studied before. One of them is called unconjugated indirect bilirubin, which is water insoluble. This one is water insoluble. And for the body to be able to excrete it, it is conjugated by the liver to form conjugated bilirubin or direct bilirubin, which is water soluble. This one is excreted in the bile like that. So in the bile there is water soluble bilirubin and the cholesterol in the form of micelle. In certain situation, if the cholesterol increase or the indirect bilirubin increase, this will lead to the formation of a stone. Again, I want to remind you, these are the types of stone, gallstones. Gallstones are formed of normal bile constituent. We have cholesterol gallstones and pigment stones. Both are normal bile constituent formed under circumstances, certain circumstances we are going to discuss later. When this indirect bilirubin increase, when this cholesterol increase and precipitate to form the stone, we will know from the causes of gallstones. Okay? Okay. To talk about gallstones, is it important to study? Sure. It's very common disease. 10 to 15% of the population are present here in USA, because we don't have accurate statistics about the gallstone in our locality. 80% of them are asymptomatic. But take care, 1 to 2% of these patients will be asymptomatic each year. Sure, all you know that it's more common in female fatty fertile. Remember this. So 2 to 3 times more in females than in males, somewhat related to the sex hormones, especially progesterone, which decrease the contractility of the gallbladder, leading to stasis and stone formation. You know, cholecystectomy is a very common elective procedure all over the world. This is the incidence, and that's why gallstones, again, is very important. These are the types of gallstones, as I told you. We have 2 main types, cholesterol and pigment. Both are normal bile constituent, but they form stones in certain circumstances we are going to study later. If you notice from the table, cholesterol stone formed about 90% of gallstone, while pigment stone form only 10% of gallstone, but this is somewhat reversed in Asia. In Asia, 80% of the stones are pigment stones. Why we call them cholesterol or pigment? According to their composition. So if the main constituent is cholesterol, it will be cholesterol stone. If the main constituent is bilirubin, it will be a pigment stone. Okay? If we want to know more about these stones, these are the cholesterol type 1, main formed from cholesterol and other constituent. As you see, they are multiple, variable in size. Faceted, has multiple faces. I mean, this face, and it is 10% radiopaque. It gives signet ring. Signet ring because calcium precipitated here, while here is a mucus plug. So this is radiolucent. This rim is radiopaque, giving the signet ring appearance we are going to see in the X-ray. Another type is cholesterol type 2. It's formed only from cholesterol, nothing else. Usually it is solitary, not multiple. It is big in size, it is oval in shape, has mammillated surface, small nipple-like structure like that. It is radiolucent because it's formed totally from fat, which is cholesterol. The third one is black pigment stone. Black pigment stone formed from insoluble bilirubin. You know which bilirubin is insoluble? Exactly. It is the indirect one or the unconjugated one. When this increase in bile, it increase in case of hemolytic anemia, all types of hemolytic anemia, increase in liver cirrhosis. In both situations, there is unconjugated bilirubin excreted in the bile. Either the liver cannot conjugate all bilirubin present, or the unconjugated bilirubin is big enough and it exceeded the capacity of the liver to conjugate it. It looks like that. We have a last type of this biliary stones. It's called a brown pigment stone. What I want you to know, it's formed mainly in the bile duct due to these causes. Usually in bile stasis, if there is bile infection or foreign body like a stitch or a stent, it leads to formation of this brown pigment stone. Again, it is not a gallstone, it's a primary bile duct stone. It's formed primary in the bile duct, not formed in the gallbladder. We finished the stone, we reached why this stone is formed, what are the certain circumstances that leads to the formation of stone. Sure, cholesterol stone is predisposed by these very common items, either the 4F, the female, above 40, fertile, and the fatty, BMI more than 30%. More in fair personnel, especially with fatty male, oral contraceptive because estrogen increases the cholesterol secretion. Loss of bile salts, especially if there is resection or of the terminal ileum or disease in the terminal ileum. In case of Crohn's disease, there is no enterohepatic circulation of bile, so the bile salt decrease. This is decrease of the bile salt. This increase of cholesterol, both will lead to disturbed bile salt to cholesterol ratio. So the micelle is not formed. There is cholesterol without a micelle precipitate and form cholesterol stone. So all these factors leads to formation of cholesterol stone, while these factors leads to formation of exactly black pigment stone. Either increase the concentration of unconjugated bilirubin in the blood, or the liver is diseased, cannot conjugate the normal value of bilirubin in the blood. The others are causes of brown pigment stone, which, as I told you, is a primary duct stone, not formed in the gallbladder, formed primary in the bile duct. Thanks God we finished a very long introduction. We are now near to discuss the spectrum of gallstone disease. I just want to remind you, asymptomatic is the main presentation, as I told you before, of the gallstone. But the most common presentation of gallstone are like that: biliary colic 56% and acute cholecystitis 36%, and that's why this is the first two items we're going to discuss. This is the very big spectrum I showed you in the first slide. We are going to discuss each item, but we're going to concentrate mainly on biliary colic, acute cholecystitis. All of these we are going to discuss this in more details, but we are going to pass rapidly on these items. Starting with the biliary colic or the chronic cholecystitis. I prefer the term biliary colic because I'm a clinician. I'm interested with the presentation of the patient. The patient presented with this colic. But chronic cholecystitis means there is chronic inflammatory sign of the gallbladder. It means if you take biopsy from the gallbladder wall, you will find the fibrosis, you will find the chronic inflammatory cell, you will see the peritoneum losing its luster and the wall is thick. These are pathological terms. What's important to me, patient with this gallstones and the chronic cholecystitis will be presented with biliary colic. So I have to know more about this biliary colic. This biliary colic, if you take a good history and analyze the pain, one of the skills you have to know how to analyze pain, take history from patient coming with abdominal pain, you will find that this pain usually is precipitated by fatty meal, starts midnight or after midnight, remains for 1 to 5 hours, not more than that. If it increases more than 6 hours, I have to suspect acute calcular cholecystitis, not simple biliary colic. Its character is dull aching. Usually it's a site in the upper right quadrant, referred to the right shoulder and the back and the epigastrium, and you understand why this reference. Finally, it is associated with nausea and vomiting. This is the analysis of the biliary colic you have to know. If you take history and you find that, you can easily diagnose this patient having biliary colic. Might be associated, if you take a complete history, this might be associated with fatty food intolerance. He feels discomfort, especially after fatty meal. Usually he is complaining that his abdomen is distended, complaining of flatulence, repeated eructation, usually have indigestion. Few patients might have this reflex symptoms with cardiac links, some cardiac manifestation, something like that. If you find a patient with this typical history and you want to make sure nothing big you can find on examination of the abdomen, just very mild tenderness, or sometimes you might find nothing in abdominal examination, but if you suspect, it is a very simple way to diagnose. You ask for abdominal ultrasound. It is the investigation of choice. You can see the stone as hyperechoic like that with this acoustic shadow. If the situation is like that, straightforward history, very clear ultrasound finding, so the treatment, in my opinion, because I'm a surgeon, is cholecystectomy, either open or laparoscopic. Nowadays, laparoscopic is the standard treatment for this biliary colic. Once symptomatic, it means removal of the gallbladder with the stone inside. Internal med doctor try to do another line of treatment, like trying to avoid this biliary colic by avoiding fatty diet, by giving antispasmodic, by giving some items that lead to gallbladder evacuation and avoid stasis, like olive oil, something like that. Another try to dissolve the stone, but if you know more about the dissolution therapy, you will find it is not a good option at all. This dissolution needs only with pure cholesterol stone, not all types of stone. It needs 2 years to occur and the recurrence is 50%. If you find that satisfactory, it's okay, but I found it's not satisfactory and it's not a good option in most of the cases of the gallstone. The idea goes that this bile acid will form, take cholesterol molecule from the stone, making a micelle. This is the idea of this solution. So we finished the first item or the first presentation, which is biliary colic. Typical presentation gallstones in ultrasound, the treatment is cholecystectomy, either open or laparoscopic. The second is acute cholecystitis. It differs, yes, it differs, as we're going to know in a few minutes. Acute cholecystitis is acute inflammation of the gallbladder. The incidence is like that. 20% of patients with biliary colic. So patient having chronic calculous cystitis, 20% of them might suffer from acute cholecystitis. But I want to tell you, the incidence is falling. Why it is decreasing nowadays? Because most people are accepted to do cholecystectomy once they have biliary colic. So there is no enough time for acute cholecystitis to occur. That's why this incidence is decreasing or falling. But strangely enough, in spite that gallstones are more common in females, acute cholecystitis are more common in males, and even the attack is more severe. I have no explanation for that. This is the instance. What usually occurs? The etiology, as I told you, 95% due to obstruction of the cystic duct by one of these stones. One of the stones move and obstruct the duct, leading to sequence of events I will discuss in the next slide. But we have another rare type. Only 5% might have acute cholecystitis without a stone. I'm just giving a brief idea, and I'm not going to talk about them again. Usually in patients with bad general condition, like ICU patient, severely ill, like patient with major pain, patient with HIV infection, patient with TPN, prolonged fasting, very rare situation, embolism of the cystic artery, or anatomic variation if the patient having floating gallbladder. Floating means he have a mesentery and the gallbladder is hanging at the undersurface of the liver, so it can twist and rotate upon its own mesentery. Rare situation, 5% of acute calcular cholecystitis, but we are going to discuss in details about this 95% in which one of the stones move to obstruct the cystic duct, which is the first step of acute calcular cholecystitis. This is the scenario. Chronic calcular cholecystitis, stones in the gallbladder. One of these stones move and obstruct here. This will lead to distension. Distended by what? By mucus, because the gallbladder can only secrete mucus. This is the first stage, is catarrhal cholecystitis or mucocele of the gallbladder, in which the inflammation is limited only to the mucosa. If this remains for a long time, secondary infection superimpose, and this mucus will change into pus, and it will be separative gallbladder or pyocele of the gallbladder. The omentum adhere to gallbladder in this situation. Again, in a very, very rare situation, if this continues, the gallbladder will become gangrenous and perforate. But why I'm saying this is rare? Because the classic scenario is like that. If the stone obstructs the cystic duct, the gallbladder distend. When it distends more and more, so here there is dilation here in the infundibular near the cystic duct, so the stone disimpact and return back again to the gallbladder cavity, and returning to the first situation, which is chronic calcular cholecystitis. So this is the most common scenario. The rare scenario is being gangrenous and perforated. As I told you, resolution in 90% of cases due to this impaction, and you understand that the scenario. A very rare situation, it might be complicated. All the complications are rare. One of them is perforation. Perforated gallbladder is very rare because it's a distendable organ. Even if it perforates, it leads to localized abscess, not generalized peritonitis. Why is that? You remember the second slide. The omentum, due to recurrent attack of inflammation, move and surround the inflamed gallbladder, isolating it from the rest of the peritoneal cavity. So it leads to abscess rather than peritonitis. Very rare situation if there is fistula between the gallbladder and the duodenum, leading to gallstone ileus. We are going to discuss obstructive jaundice also. Usually it does not occur. It occurs in a rare situation which is called Merezi syndrome. Okay, what might be the presentation of acute cholecystitis? The pain is exactly like biliary colic with some difference. One of the very important difference, it remains for long times, more than 6 hours. Again, there might be low-grade fever. If we complete examination, you will find tenderness and rigidity on the right hypochondrium. You will find, if you complete investigation, you will find the leukocytosis and certain finding during ultrasound. These are the 5 differences between biliary colic and acute cholecystitis. They are 2 manifestations of the same disease. The disease is gallstones, might be presented with simple colic or might be presented with acute cholecystitis, and I think now you can differentiate between both. 70% of these patients have a history of this biliary colic, the simple one. Usually any pain is associated with nausea and vomiting due to associated pylorospasm. If you examine this patient, you will find fever, as I told you, and tachycardia related to this increase in the temperature. If you examine, again, this is one of the differences, tenderness and rigidity in the right hypochondrium. You find a very characteristic sign which is called the Murphy sign. Murphy sign, what's Murphy sign? You do deep palpation at the right hypochondrium and ask the patient to take deep breath. The patient stop breathing when the gallbladder touches your hand because it's painful. That means that the gallbladder is inflamed. Also, at some certain situation, the gallbladder might be palpable during examination. You remember the gallbladder is palpated by the superficial palpation, and you have to know its surface anatomy at the fundus. Here, a picture, laparoscopic picture of a biocele of the gallbladder. How can I differentiate between mucocele and biocele or empyema of the gallbladder? Sure, empyema, the general condition is more bad. The patient is very ill, the high-grade fever, and the marked rigidity and tenderness instead of mild one. After the clinical picture, I have to remind you with the differential diagnosis. What's the differential diagnosis of patient having pain in the right upper quadrant? This pain might be related to the GIT, might be related to the urinary system. The GIT might be biliary pain, either cholecystitis or cholangitis or even liver abscess. It might be related to retrocecal appendicitis. Subhepatic appendix might be related to perforated DU or pancreatitis. Also, intestinal obstruction and amoebic liver abscess might lead to that. I told you the origin of pain might be related to the urinary system in case of right acute and chronic pyelonephritis or pyonephrosis. So, in taking detailed history, you can see associated urinary symptoms or associated GIT symptoms, and sure, investigation will help. If you suspect acute cholecystitis, the investigation of choice again and again is abdominal ultrasound. All of these have their own disadvantage. Plain X-ray, a few percentage of gallstone are radio opaque. The most are radiolucent, so it's not beneficial. Oral cholecystogram, it is obsolete. CT, it's sophisticated one, it needs contrast. So I can diagnose with non-invasive one. Why I have to give contrast and wait for a long time and expose the patient to much more radiation? HIDA scan, it's radioactive material. So if you notice this imaging modality, you will find the only suitable one is abdominal ultrasound. Laboratory, sure, CBC, leukocytosis, liver function, you will find the bilirubin is normal. As I told you, jaundice in acute cholecystitis is a rare situation. Let us discuss one by one, concentrating mainly on the ultrasound. In the abdominal ultrasound, you might find that you can sure see the stone hyperechoic with its acoustic shadow. You can see the thick-walled gallbladder. You can see the pericholecystic fluid, this black rim, pericholecystic fluid. You can do what we call sonographic Murphy. What sonographic Murphy? You put the probe of ultrasound over the fundus of the gallbladder and ask the patient to take a deep breath. He will withhold the breath when the gallbladder is squeezed between the probe and the liver. This is the same Murphy sign you do in the clinical examination, but you do it with the probe of ultrasound. 95% sensitive, so it is the investigation of choice. Another picture, here is the gallbladder, stone, acoustic shadow, same stones, acoustic shadow. Each stone has its own acoustic shadow. Single stone here with big acoustic shadow. As I told you, plain X-ray is not so important. One of the interesting findings is that a signet ring, radio opaque at the periphery, radiolucent at the center. You understand why the calcium is precipitated at the periphery Another signs, rare situation if you want. We have plenty of x-rays, but it's not beneficial nowadays. Ultrasound is the investigation of choice. Oral cholecystogram, you take dye orally and you image the gallbladder only and give the patient fatty meal. It will contract like that. This is before fatty meal, after fatty meals, need 24 hours to be done. Very big percentage of false negative, so we do not use it nowadays. It is obsolete. CT, sure, CT is beneficial. You can see the stone, you can see the distended gallbladder, but I told you it needs contrast and it needs more time. HIDA scan also diagnostic for acute calcular cholecystitis. In acute calcular cholecystitis, you cannot see the gallbladder because the cystic duct is obstructed. Usually you give radioactive material taken by the liver, excreted in bile. Usually, if there is no obstruction of cystic duct, it will be concentrated here, and you can see that. If there is acute cholecystitis and there is a stone here in the cystic duct, so no radioactive material here, so the gallbladder is not visualized. I don't have to say it's not commonly performed. We need radioactive material, so it is not logic. So again, classic clinical picture. You put the items of differentiation between biliary colic and acute cholecystitis. You ask for abdominal ultrasound. If the diagnosis like that, the treatment is straightforward. The treatment, in one word, is cholecystectomy. All of them are performed laparoscopically. Only there is some controversy about the timing. Am I going to do cholecystectomy at the same admission with cholecystitis? Or because I know the resolution occurs in 90% of cases, so I will discharge the patient and asking him to come back to do cholecystectomy. But again, the treatment is cholecystectomy. The controversy is only about the timing. As I told you, most of us prefer routine only on the same admission. Admitted with cholecystitis, prepare rapidly and do the operation. What's the advantage? The adhesion is still fibrinous. The patient admitted once, so socioeconomically it's better. Lab cholecystectomy in acute cholecystitis is somewhat easy because of the learning curve is high nowadays. It avoids complication. As I told you, 90% improve, but 10% do not improve. The other group, which is a few percentage of surgeons prefer to give conservative treatment like Ushner Sherin and ask a patient to come after 3 months to remove the gallbladder in an elective way. The advantage, they say that laparoscopic dissection in edema is more difficult. I do not agree. Surgery is not optimal. They mean that the patient might have some comorbidities like hypertension, diabetes mellitus. If we do it rapidly, you might not able to control them. Okay. Finally, the logistic difficulty. Usually, if you do it in on an emergency base, so usually done by junior surgeon. If it does at night or early in the morning, junior surgeon, not senior one. If you accept that, so you will prefer the other option. But me, I prefer to be removed at the same admission. What I'm going to do, what's the conservative treatment I'm going to do? Nothing for oral, intravenous fluid, intravenous antibiotic, analgesic follow-up, subsequent interval cholecystectomy. It looks like the Ushner-Sherin protocol for appendicular mass. Now we finished the second item, which is acute calcular cholecystitis with 8 stages. I just want to show you, sorry, some laparoscopic images of acute cholecystitis. You can see here the gallbladder is markedly distended. Usually, if the patient is fasting, it will be collapsed. To be able to manipulate this gallbladder, we have to aspirate the contents with long needle like that. After dissection, we are able to retract it. It is the same case, by the way. We dissect here to separate the cystic duct and cystic artery. Then we do clips and the cut between the clips, 2 here proximal and 1 distal, and the cut in between, repeated on the cystic artery, and then we remove the gallbladder from the gallbladder fossa. Okay, as you remember, the third presentation of the gallstone might be calcular obstructive jaundice. when discussing any complication, I want to remind you, I have to know how this complication occurs, how to diagnose, and how to treat briefly. Okay, pathogenesis, how it occurs. Very simply, one of the gallstones passed from the gallbladder and impacted in the common bile duct. This is the most common situation. If another situation, it's a primary common bile duct stone, which is the brown pigment stone, it's a rare one. But the common one, it's a secondary to gallbladder stone. Usually it impact, and this impact that exactly occurs in the gallbladder in acute cholecystitis, but occurs here in the lower end common bile duct. The problem here, this obstruction might lead to another complication, which is ascending cholangitis, which we are going to discuss later on. What's the clinical picture of such patient? Exactly, remember that. It will be yellowish discoloration of the sclera and the skin and mucous membrane like that. If you ask the patient about his stool, it will be pale stool because there is no bilirubin, there is no bile in the stool, stericobylene. Also the dark urine due to the increased amount of uropilinogen. The patient, due to increased bile salt in circulation, there will be itching, and you will find the itching marks during examination. It will be bradycardia also due to increase the bile salt in circulation. Sometimes this bradycardia is not present if the patient having ascending cholangitis. Why? Yeah, exactly, because in ascending cholangitis there is fever. Fever leads to tachycardia, so this might not be present in case of ascending cholangitis. This is a clinical picture very simply. So in the situation like that, what will be your investigation of choice? Your investigation will choice sure will be cholangiography, and the best one is MRCP. I'm going to show and remind you in the next slide. But other investigation like laboratory sure the first one is bilirubin. You will find increased serum bilirubin, especially which one, the direct or indirect. Exactly, in calcular obstructive jaundice, the direct one is increased more. Sure, you have to measure the alkaline phosphatase. You have to do prothrombin time because this obstructive jaundice, there is decreased absorption of fat-soluble vitamins like vitamin K. So vitamin K dependent clotting factor is decreased. The patient suffer from bleeding tendency. So I have to do prothrombin time and activity, something like that. Ultrasound, it is important, but here in obstructive jaundice is not the investigation of choice. We can confirm the presence of gallbladder stones. Sometimes you might find the clue, the common bile duct or the intrahepatic biliary radical dilated, but it's not always. You might visualize the common bile duct stone, but not usually, because many parts of the bile duct is present behind the duodenum and behind pancreas. It is not easy to see with the ultrasound, abdominal ultrasound. I want you to show the cholangiography here, some sort of ERCP, endoscopic retrograde cholangiopancreatography. In this situation, you might find mild dilation of the intrahepatic biliary radical. You can find dilated common bile duct like that. You can see filling defect here and no passage of the dye to the duodenum. Also in this MRCP, you can find dilated common bile duct. You might find this filling defect. But in this situation, the bile passed to the duodenum. How to read MRCP? I think you know how to do that, but I'm going to revise with imaging of acute abdomen. So here is how to diagnose. This is a clinical picture. Here is the investigation, and finally the treatment. What will be the treatment in calcular obstructive jaundice? Exactly, I have to prepare the patient first to guard against complication. To guard against cholangitis, I have to give antibiotic. To guard against bleeding, I have to give vitamin K. To guard against renal failure, I have to give mannitol. To guard against liver impairment, I have to give glucose 10% as a nutrition. So these are the 4 items as preoperative preparation for jaundiced patient. After this preparation, the treatment of choice is like that, is ERCP, sphincterotomy, and stone extraction. With the endoscope like that, which is side viewing one, we can visualize the opening here. We can pass a knife and cut the sphincter, so the lower end is open like that, so I can introduce Dormia basket or Fogarty catheter to extract the stone. So the treatment of the choice is sphincterotomy and stone extraction. If this is not available or failed or contraindicated, I can do open common bile duct exploration. This is the treatment of calcular obstructive jaundice. I hope you understand it and you remember it from semester 8. We finish another issue. We are going to another presentation of gallstones, which are plenty, and as I told you, it was to be revised in the final year in the week of acute abdomen. Ascending cholangitis, again, how this happened, as I told you, stone obstruct the common bile duct, leads to stagnation of bile in the bile duct. This stagnation changes the non-pathogenic organism into pathogenic, leading to pus formation of the bile duct, and the infection pass from the site of obstruction up to the liver, leading to sometimes hepatic abscess, and that's why we call it ascending. The infection ascended from the lower end common bile duct up to the liver. The clinical picture is a very characteristic triad. I think you remember it from semester 8. The triad consists of fever, usually is 5 with rigor, this is number 1, jaundice, which is intermittent, and abdominal pain. These are the 3 manifestations of the triad, the Charcot's triad, in case of obstructive jaundice. How you are going to treat? The treatment mainly is intravenous antibiotic. You have to do fluid resuscitation, but the pus in the common bile duct must be drained. Urgent ERCP or urgent BTC. This is the way how I'm going to drain the pus in the common bile duct. This is how to treat the ascending cholangitis. Very simple to remember ascending cholangitis like that. Acute biliary pancreatitis. We have a separate lecture about pancreatitis in semester 8. Again, with the same technique, how this occur by gallstones, how to diagnose and how to treat. How to occur, as I told you, obstruction of the pancreatic outflow by stone in the lower end common bile duct. It obstructs the common channel between the common bile duct and the pancreatic duct. Leads to premature activation of pancreatic enzyme. This activation of pancreatic enzyme leads to autodigestion of the pancreatic tissue. So in acute pancreatitis is autodigestion of the pancreas rather than inflammation of the pancreas. Clinically, the patient suffer from abdominal pain. The topic of the week, this abdominal pain in the epigastric region, it is referred to the back. As you remember, it's increased by lying down and decreased by leaning forward. When you will find the patient, if you examine the patient, you will find him sitting in the bed and leaning forward like that, because leaning forward makes the viscera to be pushed away from the diseased pancreas, so it decreases the pain. How to diagnose? So one of the investigation, very important one, is the serum amylase. All of you, it is not specific, and one of its main disadvantage, it is elevated only in the first 3 days, and after that it returns to normal. The much more specific is the lipase, the serum lipase and urinary lipase. Lipase and amylase are pancreatic enzymes increased in circulation due to destruction of the pancreatic cell by the autodigestion. Ultrasound is not good. You know ultrasound from the lecture of trauma. Ultrasound is not good in retroperitoneum, and the pancreas is nephroperitoneum. Just confirm again the gallstone. But again, the investigation of choice is CT. So again, I want to remind you, in biliary colic and acute cholecystitis, the investigation of choice is ultrasound. In calcular obstructive jaundice, the investigation of choice is cholangiography, and namely MRCP, because it's non-invasive. If you suspect acute pancreatitis, the investigation of choice is CT, because this is the gold standard. It can grade the pancreatitis from mild, moderate, severe, or hemorrhagic pancreatitis. Many methods of grading, the Ranson criteria, the TT scanning, but the treatment, mainly it's medical treatment by analgesia, fluid resuscitation. You rinse the pancreas, clear the fluid, butyrol, nothing per oral, identify the cause. Is there a rule of surgery in case of pancreatitis? Yes. If there is pancreatic necrosis by the CT, I can do this necrotectomy. I can treat the cause by removing the gallbladder and the gallstones, And lastly, I can treat the complication like pancreatic pseudocyst. So 90% of the treatment of pancreatitis is conservative. Is there a role of surgery? Yeah, a role of surgery to treat the cause of pancreatitis. I mean to remove the gallstones. Second, in necrotic pancreatitis, I can do necrotectomy. I can remove the necrotic tissue. Third, to treat the complication, namely the pseudopancreatic cyst or pseudopancreatic abscess, which is treated surgically. Finally, the gallstones, again and again. How it occurs, how to diagnose, how to treat. How it occurs, exactly as you said. By pressure necrosis, there is a fistula between the gallbladder and the duodenum. It's called the cholecystoduodenal fistula. Through this fistula, a large stone, usually large stone, 2 centimeters or more, pass through this fistula to the duodenum. And to the duodenum through the fistula, not through the compile duct. During its pathway down to the intestine, it collected the fibers and the food residue around it. It enlarged like a snowball, so it enlarged in size till it reached the narrow terminal ileum. It impacted about 60 centimeters from the ileocecal valve. How to diagnose? By X-ray, you'll find a dilated small bowel, like any intestinal obstruction. You might find radiopaque stone in the right iliac fossa, not in the right hypochondrium. You might find the gas in the biliary system. The treatment, sure, is surgical. I have to explore the 3 R's of intestinal obstruction, if you remember. Ryle, resuscitate, and surgery. You explore, you either fragment the stone. If you fail, you do enterotomy and remove the stone and close the intestine again. This is how the fistula is formed. Big stone pass through the fistula like that. This is radiopaque shadow in the right iliac fossa in case of gallstone ileus. This is intraoperative finding. This is after enterotomy and removal of stone. I hope you can remember all types of presentations of gallstones. Many of them lead to acute abdomen, and most of them are treated by cholecystectomy. After all this discussion, we still have indication of removing the gallbladder due to silent gallstone. It's called the prophylactic cholecystectomy. You might be able to read them. You are going to conclude that gallstone equal cholecystectomy. If the whole lecture giving you idea when to remove the gallstone, when it is symptomatic or complicated, and the last slide when to remove the gallstone even in asymptomatic patient. Thank you. I hope you got benefit. Till we meet in another lecture. Goodbye.